but never for University of Washington Grand Round, so I thank you very much for the honor. We are going to be talking about something that I've never talked to this audience about, and something that has been a lot of fun for us in the Diabetes Care Center over the last couple of decades, and that has been the evolving use of technology for the management of diabetes. First, my disclosures. This is a CME. You can see my research and my little consulting, and I will tell you that I am telling the truth. And just to make sure for everybody in the audience, I even included these Torahs here, just to make sure my point is made. Now, by way of introduction, the discovery of insulin 91 years ago was, I think we would all agree, one of the most important advances in medical history. And these are the two gentlemen who actually did the work. This is Sir Fred Banting, who is the surgeon, and this is Charles Best, who at the time was a medical student. Very important. Now, Mr. Best, later Dr. Best, did not get the Nobel Prize. Dr. Banting shared it with him, but just for the medical students in the audience, you can do some pretty amazing things with your spare time in the summer. Now, the initial preparations were crude, they were impure, they resulted in many problems, but most importantly, they did not cure diabetes as initially envisioned. Furthermore, there were no good ways to monitor the diabetes at home. And as a matter of fact, when insulin was discovered, the Canadian government in 1927 decided, we've solved this problem, let's now go cure cancer. That was the Canadian government. Notice these early vials of insulin. This is U20. This is actually an earlier vial of U10 insulin. And it's kind of interesting as I think about this now. Yesterday in my clinic, I saw 2 patients on U500 insulin. So we've certainly come a long way since the early 1920s. The initial assessments of diabetes control was difficult at best. This is what was used at home to test urine in the 1930s to 1960s. Dr. Bremner, you probably remember this from your days in training. But it was like a chemistry test, and this is what was used. Yeah, I'm glad you're in the front row, Dr. Bremner. Yes. Yeah, there we go. But the technology assessment of diabetes control and insulin dosing, the technology was interesting as we assess glucose control. Now, there actually may be people in the audience who do remember this, the urine testing that we used without the match, without the burning. And the question is, are we done with urine for the diagnosis and treatment of diabetes? Well, I'm not sure we're completely done with it. I didn't know you had this pool heated. Well, that's one way to look at it, but I will tell you that in the UK, the National Health Service is funding a study. They have funded a study in patients with type 2 diabetes looking at urine versus blood glucose testing, and we may hear about this large government-funded test before the end of this year. My colleague Simon Heller in Sheffield is running this study, and the study, I was told last week, was just completed. So we're going to be hearing more about this as we learn of different ways to decrease the costs of diabetes. If we think about glucose monitoring for a moment, it's interesting as we go back and look at some of the history that the original dextro stick was developed in 1964. And this first dry reagent glucose test strip used immobilized glucose oxidase with horseradish peroxidase to be used as a color indicator. Some of you may remember these initial dextro sticks. But there are a lot of limitations to this. It was a huge drop of blood. Remember this number, 30 microliters. We'll come back to that in just a moment. It took 60 seconds, and then you had to wash the strip, and then you would read it after that by just looking at the color matching on the bottle of the strips. And that is how the initial finger stick glucose tests occurred. Later into the 1970s, reagent strips were developed. The initial AccuCheck strips, you could actually do reading, and people would cut these strips into halves and into thirds to try to save money as they looked at this. But then reflectance meters were also developed using this glucose oxidase methodology. In the 1980s, we had our first glucometer from Bayer, and then in the 1990s, we also had a glucometer. And I remind this to the students, residents, and fellows that this was the original glucometer. Glucometer is actually a trade name of a specific meter. So when we talk about glucose meters, we don't say the trade name glucometer, we have to talk about the glucose meters. There are no glucometers used anymore. As far as self-monitoring of blood glucose, SMBG, until 1987, this technology used an enzyme-based photonic method, mostly by measuring the change in light reflectance of this dye-containing strip, resulting in the glucose oxidation reaction. But today, the technology has improved, and that this is all performed with electrochemical methodologies, and this allows for smaller volume of blood and faster tests. And if we go back and look what was used in the early days, and this is a logarithmic scale for blood volume, using 20 and 30 microliters, this is modern day home blood glucose monitoring, less than a microliter of blood. Very, very tiny. In fact, a fraction of a microliter of blood is all that's needed. So this part has come a long way. Now, this may seem a bit esoteric, but it actually isn't. There's something called ISO. ISO stands for International Organization for Standardization. And we are still using the 2003 ISO standards today. And you need to know this, because what is needed to get a glucose test strip on the market is that for glucose levels between 76 and 600 milligrams per deciliter, the air needs to be less than 20% of a laboratory standard 95% of the time. Well, what does that mean? Well, if a blood glucose is 100 milligrams per deciliter, that means the variability in that meter can be between 80 and 120, 95% of the time, meaning 5% of the time, it's okay to be out of that range. And that is a huge problem, because this is the accuracy. And think about that for those of you who are on inpatient medicine right now. Think about that for your patients, especially for these low numbers. So for hypoglycemia, what the current standard is that for a standard less than 75 milligrams per deciliter, the air needs to be less than 15 milligrams per deciliter 95% of the time, meaning 5% of the time for your ICU patient on an insulin drip, it can be more than 15 milligrams per deciliter off. And so if you're in a hospital, this is a huge issue. We have a patient in the hospital right now who we are working up for an insulinoma. I happen to be on the inpatient endocrine service, and the medicine team watched the finger stick glucose go down and go down. And yesterday, once the glucose hit, I think it was 47 or 48, they stopped the test appropriately. The lady was symptomatic. They drew all the blood for proinsulin, C-peptide, insulin, and all the things that we do. But as it turned out, when the blood glucose was sent to the lab and came back, it came back at 55 milligrams per deciliter. Now, I saw this when I was going through the ORCA chart last night. The lab test was actually within this ISO standard, but the question is the glucose low enough for us to use this information, or do we need to repeat the fast? And as it turns out, it made the grade, but barely, barely. And that's because these meters are not exactly accurate. Now, the interesting part of all of this is all going to change. I am told by the end of this year, we are going to have new ISO standards. And what I think is going to happen is that the FDA is going to ask us to have different ISO standards in the hospital than with these home glucose monitors, where obviously somebody on an insulin drip, you would like to be more accurate than what is currently recommended. Again, this sort of seems esoteric when you look at the different enzymes that are used. I will tell you, this is not esoteric. These are the different enzymes for the home glucose meters. Glucose oxidase is the most commonly used enzyme. And if you think about it, you would not want to use a glucose oxidase-based method if you live in Denver or if you're in the mountains a lot, because the oxygen pressures are obviously lower when you are at the high altitudes. But the one I want to pay attention to is this one, the GDH-PQQ, because this is really important and is not a laughing matter. So for meters that use this enzyme, GDH-PQQ, there are certain medications that can be metabolized to maltose, which interfere with the ability to measure glucose, giving false high readings. And this has been known for years, that this turns these other substances into maltose, and the glucose meter reads it as glucose. And what we know about this, and this is an underestimate we know, is that because these maltose interference substances read the glucose level as high when it's not, insulin is given inappropriately, and reported have been 46 episodes of severe hypoglycemia and 16 deaths for insulin being given inappropriately. And the question is, well, why is that important to us at the University of Washington? Well, it's very important to us. First of all, this is one of our medical assistants, Sarah. This is the monster inpatient meter we now use compared to a typical outpatient meter that patients use. And the patients always ask, why are you using such a prehistoric meter? And this is what we use in our clinic, and this is what we use in the hospital, because this is what is approved for. So that's obviously an issue. But here's what the PQQ interfering substances are, and you can go down them. This substance here, the icodextrin, this is what is used in the peritoneal dialysis. But not all peritoneal dialysis fluids have this, but most of the deaths have been from the icodextrin being converted to maltose, being looking like it's glucose, and people getting insulin inappropriately when the glucose levels are significantly lower than they actually are. IVIG is used a lot in the hospital for certain situations. This is a drug that I see a lot coming from Greg Gardner in the rheumatology clinic. The point is there are all these drugs that give you falsely high glucose readings with the meter that we use at the University of Washington Medical Center. Now, I can tell you that this particular meter is over 90% of the meters of the hospitals in the United States, and I can tell you the company that makes this meter is trying to get their new strip approved. It's not been approved yet, but the point is if you have a patient coming in on one of these drugs, you need to use a different meter. So, thinking about University of Washington patients in our hospitals and clinics and looking just at blood volume for a moment, it's actually kind of interesting. This is our typical outpatient volumes that our patients use. This is what we are using in the hospital. And what it is really is I just don't think as much resources have gone into the in-hospital meters as we see, but you can see why patients really dislike getting their blood glucose checked in the hospital. Not only that, but these outpatient meters are now less than 5 seconds, and the inpatient meter is 26 seconds. And so with the administrators in the audience, and you have somebody getting a glucose reading every hour, think of the time, and Mark Holter, think of the money this costs with all of the time we're waiting for the glucose meter. But we're stuck with this, so you just need to know what the limitations are. And this is the 3 a.m. glucose check at University of Washington. This is what the patients think, because it truly is barbaric. So where is glucose monitoring technology going? Obviously, it's going to the smartphone. And we actually have our first iPhone meter out called the IBG Star. And as it turns out, this is the first glucose meter to connect to an iPhone. And I can tell you that these meters connecting to smartphones will be common within the next few years. And patients will come in with their smartphones. You'll look at their download on the phone, and it will be connected to the cloud. This isn't the distant future. It's the immediate future. So my conclusions about this part of technology is that more than any single technology, home blood glucose monitoring has allowed us to better control and assess the importance of good control, both at home and in the hospital. More than any single technology, the limitations of home blood glucose monitoring need to be appreciated. And more than any single technology, home blood glucose monitoring frustrates patients. I mean, patients look at the data, and this is what they see when they do their blood glucose check. It really is a humbling experience. Now, moving on to another technology. What about insulin pump therapy as an option for insulin delivery? Well, this is how we all started. Could you imagine being a medical student in the emergency room and somebody coming in with their insulin pump looking like that? Well, that was the first one, and we've obviously had quite an interesting evolution. In the late 1970s, this blue brick, to the early 1980s, to the late 80s and early 90s. And when we look at this, the explosion of insulin pumps are huge. In fact, when I was asked to give this grand rounds in the spring, the main reason I think is because of all the patients coming into the hospital on insulin pump therapy. We are all seeing it now. The explosion has been huge. And one of the things that a lot of people think was a big reason for this explosion was in 1999 when Miss America, Nicole Johnson, was queened Miss America, and she took diabetes on as her main focus, and this was really a great stimulus for the young teenage girls to start wearing insulin pumps. But obviously, as you see this growth, this is more than just teenage girls wearing insulin pumps. This is a lot of people. In fact, in the US, we now believe there are 400,000 Americans wearing insulin pumps, and around the world, it's over 600,000, and this includes both type 1 and type 2 diabetes. Why have we seen such a growth in CSII? That stands for Continuous Subcutaneous Insulin Infusion. CSII, insulin pump growth in the United States. Well, as I'll show you, a slight improvement of glucose control and variability of blood glucose, reduction in hypoglycemia. And that's the big thing. We thought when insulin pumps became popular that we would see more hypoglycemia. Actually, it's the opposite, because we can change the basal rates of the insulin much more effectively with tiny doses of insulin for exercise, for illness, and a lot of other things. The big issue is most people who stay on insulin pump therapy, it's because better quality of life. There have been several studies done in type 2 diabetes. There have been meta-analyses. None of the studies have shown improvements of glycemic control in type 2 diabetes with this technology, but every study has shown an improvement of quality of life with insulin pump therapy. Better ability for downloading insulin data. We just can't look how the patients do when they are using pens or syringes because there's no real good way right now to accurately assess that data. Further integration with continuous glucose monitoring, CGM, which we'll talk about in a moment. Better integration of the pumps with the sensors, which is obviously something that a lot of people are excited about. And then why we see better hypoglycemia rates is more precise delivery for those who are very insulin sensitive. That's 0.05 units at a time, tiny doses, or even for those more resistant, as we are using U500 insulin more and more in insulin pump therapy to better guide therapy. So these are the reasons, and I will tell you where we are seeing explosions of insulin pump therapy are in the very young, the under 6-year-old. And in fact, looking at the data, we are involved in a very large study, an observational study with the Leona Helmsley Foundation. And yes, the Leona Helmsley. She didn't give all of her money to her dog. Actually, much of this money is going for type 1 diabetes research. And we are involved in a study where we now have 26,000 people around the US with type 1 diabetes, 67 diabetes centers. And we are at 26,000 now. These are data we presented in Barcelona when we had 20,000. And if you look at all of the different age groups, you see a tremendous amount of insulin pump therapy, even in the very young. And for the group as a whole, it turns out it's 54% of these type 1 patients out of the 26,000. 54% are on insulin pump therapy. And what's very interesting to me, when Dr. Trentz and I looked at our data earlier this year at the Diabetes Care Center, it is also 54% of our type 1 patients are on insulin pump therapy. So this is a therapy that is used quite commonly. Why is it so popular? Well, it's because we can better mimic normal insulin secretion. If we look at mealtime insulin, we look at background or basal insulin, the non-diabetic beta cell secretes both, the background insulin for suppressing the liver, the mealtime insulin for moving the glucose into the muscle. And what we do with the insulin pump therapy is we can mimic this better than we can with multiple daily injections. So physiologic insulin secretion is the gold standard for type 1 diabetes. The question is insulin pump therapy a better way to deliver than multiple daily injections? And this has been a hotly debated topic for the last 2 decades. From just a theoretical point of view, you would think it would be, because we can change these basal rates with different basal rates during the day. We can turn it down at night when insulin needs are less and when hypoglycemia is more likely to occur. And we can turn the basal rate up in the morning when insulin requirements are greatest. And this isn't just somebody with diabetes. This is pretty much everybody requiring these different basal doses. What single factor can usually predict success with insulin pump therapy? It's pretty obvious when we go and look at all the data. It's checking the blood sugar frequently and having the data to frequently make adjustments in the glucose in the insulin based on the glucose levels. What else makes a good candidate from a patient perspective? Somebody who is counting their carbohydrates or using some system for estimating how much insulin to give for the meal. Frequent glucose testing, we have found, can make up for somebody who doesn't carb count well. They're checking constantly, 8 times a day, 12 times a day, 14 times a day. And if they don't get the carb counting right, they actually do fine because they're constantly changing their insulin or eating little snacks. And then, of course, we have patients who do the WAG methodology of insulin delivery. Does anyone know what WAG is? Wild ass guess. That's right. And some people do very well with this. They do very well with wild ass guessing how much insulin to give because they've been doing it for years and even for decades. And then we have the very sophisticated wild ass guess for those who are further along down the line. Understanding the basics of insulin therapy, knowing how to correct both before meal and after meal hyperglycemia. And we'll talk more about this in just a moment because it is different. What makes a good physician candidate successful? Now we're really getting to the nitty-gritty. I would say first and foremost is time to spend with the patient. If we are doing our current treadmill right now and you are spending 8 minutes with the patient, you can't do this kind of therapy. You actually need good face-to-face time. You also need a team, which does not need to be all on site, but the providers with the same philosophies of insulin use. We've been very fortunate to have this type of support and resources over the last 22 years at the Diabetes Care Center that we can all do this together as a team because a physician by himself or herself cannot do this. An infrastructure in the office or clinic to use the technology most effectively, and this would include the whole topic of downloads. I don't know how we could take care of these patients, and these are pump patients and non-pump patients without these downloads. But as far as the pumps are concerned, you also need an infrastructure to address the many phone calls from patients and ridiculous paperwork from payers, which has become obscene with Medicare. The good news is Medicare covers pumps for type 1 diabetes. The bad news is the amount of paperwork we have to do make many physicians not want to use this therapy for that population. And that's a whole discussion that I'm sure there will be questions about. And then finally, obviously, a more than basic understanding of the principles of insulin use. This is not for somebody who's just starting to learn about insulin therapy. What is the role of the primary care physician with insulin pump therapy? And I guess it depends on who you ask. One opinion in a recent review of insulin pump therapy in the New England Journal of Medicine is that initiation of insulin pump therapy by primary care physicians is not recommended. That was one opinion. My opinion on that opinion is that that opinion is garbage. And I really do believe that because we have many physicians, not just here in the Seattle area, but around the country, who are not endocrinologists. They're primary care physicians. They have an excellent knowledge of this. They also have the infrastructure in their clinics to do this. I think that was a ridiculous statement. I actually wrote a letter to the New England Journal, and it was too long. I had too many problems with this review, and so only part of it got in. But this, to me, is the more important part. I don't think you need to be a card-carrying endocrinologist necessarily to prescribe insulin pump therapy. Now, for the residents and the students in particular, what are some pearls? Not getting to the big issues, but maybe some of the smaller details about insulin pump therapy. First of all, when patients come in on their basal insulin and they're getting 70% of their insulin as basal insulin, I know there's a problem before I start, because rarely patients need more or less than 40 to 50% of their total daily dose. And there obviously are exceptions to this, and we see a lot of these exceptions in our clinic, but most of the time, 40 to 50% of the insulin needs to be basal insulin. And the basal dose can, in my opinion, only be determined by doing basal testing, and that is what happens to the trend of the glucose if a meal is missed. And you can do this with frequent glucose testing. You can do this with continuous glucose monitoring, but that's sort of an important pearl to get the basal doses right. And as a rule of thumb, the success on an insulin pump is inversely proportional to the number of basal rates. We have patients coming in literally with 14, 16 basal rates, which is ridiculous because when you change a basal rate, it takes 2 to 4 hours before you see a change in the glucose. So you just don't need that many basal rates. Most patients require 3, at the very most 4. Sometimes we will intentionally change a basal rate because that's when they are eating and it sort of cushions their spike and they eat at that time every day. But the problem is if they're on an airplane and they don't eat at that time, they're going to get low. And so we have to teach our patients about that. Some other key concepts. The whole topic of insulin on board or insulin remaining, which we define as the amount of insulin from the last bolus which has not yet been absorbed based on the pharmacodynamic data. Now, it's important to know the difference between pharmacodynamic and pharmacokinetic. Pharmacokinetic is just measuring the insulin in the blood. Pharmacodynamic is looking at the insulin action of that blood and of the insulin. And as it turns out, the insulin actually lasts for a typical dose for one of our rapid-acting analogs between 5 and 6 hours. It takes a long time for the insulin to get into the circulation, bind to the receptor, and get that glucose into the cell. So it's not as rapid as we would like it to be, and that's the pharmacodynamic. And you can imagine if the insulin is given at 8 in the morning and there's a high blood sugar at 10 in the morning, and you give insulin to correct that glucose at 10 in the morning, you are then going to stack the insulin. And that causes a lot of hypoglycemia, more so with regular insulin than one of our rapid-acting analogs. And it is this reason for the insulin stacking that, as a rule of thumb, we don't want the nurses to be doing a lot of between-meal testing for patients who are on multiple injections in the hospital, because they don't think about and we don't teach about the insulin on board and the insulin stacking, and what happens is you end up getting a lot of hypoglycemia. What about the sensitivity factor? Again, and when thinking about insulin pumps or multiple injections, you at least have to know what this is, and this is really the correction dose, and it's the amount of glucose to expect from 1 unit of a rapid-acting analog. There are numerous formulas I won't bore you with, but as a rule of thumb, most type 1s, we start with a sensitivity factor of 50. Most people with type 2 diabetes, we start with a sensitivity factor around 30, and that just means that 1 unit will drop the glucose by about 50 milligrams per deciliter in a type 1, or 30 milligrams per deciliter in a patient with type 2 diabetes. Now, today's pumps are smarter, but they are still not totally intelligent. Let me explain what I mean by that. All of today's insulin pumps have some form of bolus calculator, which will ideally prevent insulin stacking from insulin on board, but even these systems are not perfect, as the patient must still check the glucose, understand the trend of the glucose, reasonable estimation of the carb content, using appropriate amount of time because the insulin is so slow between giving the insulin and eating, and assuming no variability of food or insulin absorption, which obviously is not the case, using appropriate insulin on board. Now, I put all of these things here for pumps, but actually the patients who don't do well with multiple injections, they're thinking about all of these things at the same time. And so you can see that somebody who, especially a type 1 patient, but even the type 2s who are doing well and take basal and bolus therapy, which is our gold standard, they're having to think about a lot of things, and they complain about it because to do well, you almost have to think about it 24/7. It's a huge burden for the patient and the family, and I don't want to minimize that fact. Let me give you an idea how this bolus calculator works. We'll just take a patient by the name of Bill with an insulin to carbohydrate ratio of 1 to 12, a sensitivity factor of 40, good basal test, so the basal doses are right. These are very typical doses of insulin. Has a premeal glucose of 210. The targets are 90 to 130. He is about to eat 36 grams of carbohydrate. He has insulin on board from an earlier insulin bolus of 0.5 units. He enters the carbohydrate amount and the glucose into the pump. And in fact, most of the pumps now, this all occurs via the Bluetooth, the radio frequency. The glucose is done with the meter. The information automatically is transferred to the pump. And what happens is the pump does the math instantaneously. This is the amount of food, the carb ratio. This is the correction dose. This is the sensitivity factor. This is the insulin on board. And instantaneously, the math is done, and it comes out that the patient needs 4.5 units of insulin, but because the glucose is high, ideally, the patient needs to wait longer between giving the bolus and eating. But the pump does the math. And this pump doing the math, and especially taking account the insulin on board, is to me the biggest advance in the pumps in the last decade, is that the math is done for the patient as long as the patient can put in the amount of carbohydrate. An important point is that the bolus calculator does not take the glucose trend into account. The calculator always sees the glucose as being flat. And this is an important point, because as you'll see in just a moment, if the glucose is going up, the pump isn't smart enough to know that, and to know that the patient needs more insulin, and if it's going down, the patient needs less insulin, because the pump always sees this as being stable. This is what the patient sees. The patient puts the information in, and instantaneously the patient sees 4.5 units of insulin is suggested, and the patient that can then override or underride that, and we can actually see on the download what percentage of the time at each time of day is the patient overriding or underriding the pump. Pretty cool? This is what's happened in diabetes in the last 10 years. So the real question is, I think, from an academic point of view, what is the evidence that insulin pump therapy is superior to multiple injections in type 1 diabetes? Well, John Pickup did a meta-analysis. We actually have one of our studies in this meta-analysis. And what he showed, the bottom line, is an improvement of A1C by 0.62% with insulin pumps compared to multiple injections. But importantly, and I think those of you who see our patients in the Diabetes Care Center know that not everybody who is on an insulin pump does well. It is not a panacea. Patients who don't do well on injections are not necessarily going to do well on pumps, and in this one survey, over a quarter of patients had very high hemoglobin A1Cs, and this just is another analysis of really the same point, that people on multiple daily injections who had high A1Cs also had high A1Cs on pumps. The pump by itself is another way of insulin delivery, but somebody with a very high A1C, what that really means is that they're not doing enough checking, they're not matching their food with their insulin well enough, they're really not doing what they need to do. In fact, I will go as far to say that anybody with type 1 diabetes with an A1C above 9% is not doing the minimum, because we shouldn't see that today anymore. A1Cs above 9%, given the technology and what we understand. Getting down to 7% is tougher. Above 9%, there's a problem somewhere. The real issue, though, with pumps is hypoglycemia. And what we see with hypoglycemia is a dramatic reduction with a rate ratio over 4, a dramatic reduction of severe hypoglycemia by about 75%, going from a multiple injection to pumps. And there was no difference when looking at the randomized trial and the before-after observational studies. Now, more recently, as in last month, there was an EPUB in the Annals of Internal Medicine looking at this same question. And what this EPUB showed was that in children, there was no difference. I mean, it favored CSII, but it actually crossed the unity line here. In adults, looking at all the studies, there was no difference. And in type 2 patients, it just missed statistical significance, showing no difference in A1C. So you have to pick your meta-analyses carefully, I guess. What the big thing that's going to happen over the next 12 to 24 months is the introduction of patch pumps specifically for type 2 diabetes. This Vigo pump is already out there. We saw somebody on the inpatient service this month on a Vigo pump. This particular pump can give you either 20, 30, or 40 units of basal insulin. You pick which size you want, and then you can bolus the insulin in. It's a mechanical pump. It has to be changed every day. This particular pump, as another example, just gives bolus insulin. This one will likely be on the market, I'm guessing, within the next 1 to 2 years at max. The point is, everybody is working on these different delivery systems, much less sophisticated for type 2 diabetes. But that brings us to where the biggest excitement is, I think, in our clinic, and this is the whole topic of continuous glucose monitoring, or CGM, and where we are in 2012. The way this works is that a sensor is put into the interstitial fluid under the skin in the subcutaneous tissue, and there is glucose oxidase here, so that when the glucose bathes the sensor, what happens is you get gluconic acid generated, but you also get hydrogen peroxide, and you get an electric current. And the greater the glucose, the greater the electric current. This current is then transmitted to a receiver, and a blood glucose is seen with a lag time generally between 5 and 15 minutes. The current sensors are not perfect in terms of accuracy, but we've certainly come a long way. The future is very exciting about this. And I will tell you with one of our sensors, because it's hydrogen peroxide, there are certain medications that have a huge problem with this, the big one being acetaminophen, that if a patient has even a small amount of acetaminophen, the hydrogen peroxide goes up right away, the glucose level looks like it goes up to 400, and that's the interference with the acetaminophen. In children and thin adults, the main problem with all this technology is not enough subcutaneous real estate. Both are used with sub-Q insertion, but finding spots can be a challenge for some and an opportunity to get on Facebook for others, as here we see in this youngster an Omnipod insulin pump and a Dexcom, and you can see the cute buns here. But all kidding aside, especially in youngsters and thin women, enough real estate is an issue. The keys to success in a typical MDI patient, multiple daily injection, let me walk you through this. Looking at the continuous glucose monitoring device often, appreciating continuous glucose monitoring lags 5 to 15 minutes behind the blood sugar, and accuracy is not yet perfect, understanding how to react to glucose trends and the difficult problems we have with insulin pharmacokinetics. And let me walk you through this. You can see that there's an arrow going up, and this is a Dexcom sensor, and this means that with this arrow going up, the glucose is rising 2 to 3 milligrams per deciliter per minute, so it's going up quickly. You can see the blood sugar is 182, but because of the lag time, it actually, since it's going up quickly, the actual glucose actually may be a bit higher, and the patient needs to know that. The other thing is that the insulin was injected 80 minutes earlier, meaning if we understand the pharmacodynamics, there's still 80% still active. So this is the curve that we give all of our patients. This is the actual curve for Lispro, for Aspart, and Glulisine, our 3 insulin analogs. And after the insulin is injected, if it's 80 minutes, you still have approximately 80% of that insulin still remaining. And so the question is, if you see this arrow going up and you want to give insulin at this time, you're stacking the insulin. If you give too much insulin, you're going to end up low. And so understanding how to reduce that dose for multiple injections is what we teach our patients, but it's obviously, as you can imagine, easier with a sensor-augmented insulin pump. And this is another patient, a 38-year-old man, who's wearing a pump and a sensor. There you can see the bolus on the download. The glucose level at the time was about 140. The bolus was what the pump told him to take. But what happened was, a little bit later, he got an alarm. He got an alarm because the glucose was at 200. The pump was set. The sensor was set to alarm at 200. So the patient went and gave a correction dose, asking the pump and the bolus calculator how much insulin to give. The patient did that, but there's a problem. And the problem is as follows. The correction dose does not take into account that the glucose level is going up. And that's very important because if you remember what I said, the calculator only sees the glucose as being stable. So in actuality, the patient needs to give more than the pump is recommending. The patient did not, and so the glucose level continued to go up, and the patient ended up getting another alarm in 2 hours because the patient did not give enough insulin, taking into account the trend. It's complicated, but many patients do very well with this therapy. And going back to our Helmsley exchange data, again, this is observational. It's not a randomized trial, but looking at the continuous glucose monitoring patients in blue at all age groups, they do better. But more importantly, what we see over and over in all of our trials is that the patients who wear the sensor the most have the best glucose control, and they also have a lower amount of hypoglycemia. In fact, one of our studies that we participated in, the JDRF CGM study, we only, in our center, looked at adults above the age of 25. Most of these patients actually were on pumps, and I want you to pay attention to this. Patients with type 1 diabetes test their blood glucose levels a lot. And one of the things that has become quite frustrating for us is getting our patients enough strips to take care of their glucose to take care of their diabetes because the strips, like the insulin and everything else, have become so expensive. But what we did was we randomized these patients to continuous glucose monitoring with home blood glucose monitoring, and we had home blood glucose monitoring by itself. And as you can see in our adults above the age of 25, we had a 0.52% reduction in hemoglobin A1C. It was a successful trial. And in another trial, which was part of this, with people with A1Cs under 7%, it was also a positive trial in that we showed a reduction of hypoglycemia exposure for people with A1Cs under 7%. So we were very happy about this. But what if we look at the children, the small children, no differences in A1Cs, and what if we look at the monsters, the 15 to 24-year-olds, no change in hemoglobin A1C, and so you say, we didn't do it, we couldn't show it in these patients, and I would say, actually we did. It goes back to how often are they wearing the technology. Because if you again look at the blue, which are people wearing it 6 or 7 days a week, it really doesn't matter what the age is. What it matters is when they wear the technology, they get a better response, they can see it. We did an intention to treat analysis, and when those patients do wear the technology, they do very well. So CGM works when it is worn. You can lead a horse to water, but that doesn't mean he will drink or wear his CGM device. Sort of the bottom line. And if we then go back to our Annals of Internal Medicine meta-analysis from last month, which is on the EPUB, what you see is that, yes, CGM indeed does do better than home blood glucose monitoring in type 1 diabetes. And what you also see is that when you do a study with CGM and insulin pump comparing to multiple injections and home blood glucose monitoring, you also do better. I personally don't think this is the appropriate trial because you are having differences both in insulin delivery and in the way glucose levels are managed, and you have two moving targets here, but these are the way the studies have been done. This may be the most important part about the recent Annals of Internal Medicine paper, and that's this. What you see is you see an improvement of A1C the greater the adherence. I don't like to use the word compliance. I think adherence is a better word to use. And for these people who adhere with their CGM, wearing it 80% of the time, they do very well. And it's like anything. If you use it, it works quite well. And if they wear it, the hemoglobin A1C level will come down. This is where we're going with this technology. Medtronic, one of the companies who is involved in this space, has the first one, but there will be more. It's called LGS, which stands for low glucose suspend. And does it reduce hypoglycemia? The answer is yes. Does it result in unacceptable hyperglycemia? And this is the FDA's problem. The answer is no. And one of the first trials on this from Satish Garg and his colleagues at the Barbara Davis Center in Denver, he exercised these patients, brought the blood glucose levels down to hypoglycemic levels. When the LGS was turned on, the glucose levels came up because the pump was turned off for 2 hours. In 2 hours, you don't see horrible hyperglycemia, and this is what the FDA is concerned about. But when you keep the glucose level, when you keep the LGS off and the pump continues to ride when there's hypoglycemia, obviously you see more hypoglycemia. And you can imagine hypoglycemia at night, how wonderful this would be to have the pump turn off so there's no more insulin delivery for those 2 hours. We had a patient on the 4th of July where his daughter found him dead in bed. And it happens, and it was hypoglycemia, and if he was wearing this device, my guess is he would be just fine today. We see this, and I'm hopeful that we get this soon. Where are we now with LGS? Well, let's look at the map of the world. I get this slide from Bill Tamberlane, a colleague at Yale. They have LGS approved in Europe. They have it in Australia. They have it in Asia. They have it in South America. They have it in Africa. And lo and behold, they even have it in Canada. But with our regulatory system here, we do not have it in the United States. I am hopeful that we get this soon because this technology is obviously a potential lifesaver. And where we are now is that we have draft guidance that we got last year on what the FDA will require for approval. We are not involved in this home LGS study. It is now ongoing. But the real significance of this is really our first step to what many people call an artificial pancreas. But I think the bottom line about the artificial pancreas project is that it's really baby steps. We need to minimize hypoglycemia. That's all LGS does. We want to minimize hyperglycemia, better algorithms, faster insulins, using amylin, using heated insulin, and even we are going to be using GLP-1 analogs, not to change the insulin pharmacokinetics, but to change the absorption of the food. And of course, we need better sensors. So I would conclude that there have been incredible advances in diabetes technology over the past decade. Nevertheless, the therapy and success today is still dependent on adherence and patient understanding of some very complex principles. And I think one of our goals is to simplify this for patients. The goal is to further refine the technology so that diabetes can be managed with little effort by the patient in a cost-effective manner. For now, we suggest that here at UW, at Harborview, or at UWMC, that for patients who come in with insulin pump therapy, they should be seen at that hospital's diabetes and endocrine clinic as an outpatient. And for patients admitted to UWMC, we now have this wonderful inpatient hyperglycemia service. And in talking to Brent Wiss at Harborview, these patients should also be, you should let Brent and his team be notified that these patients are in the hospital. We are more than happy to help you with these patients when they come into the hospital. 54% of our type 1s are on insulin pumps, so you are going to see them. I would conclude that our current successes and failures are required for us to ultimately utilize a closed-loop system, at least for the treatment of type 1 diabetes. We have made some mistakes, and perhaps I can end this grand rounds with this very appropriate quote from Mickey Rooney: "You can always pass failure on your way to success." I want to finally thank all of my colleagues, both in clinic, my research colleagues. There are many of them that I work with here and I collaborate with. I want to particularly thank Dr. Jerry Palmer, who in 1989 saw this young endocrine fellow from St. Louis who thought he could take on this job. And it's been a lot of fun for me, and I want to personally thank Jerry for allowing me to have so much fun.